When someone rushes to the hospital with chest pain, it kicks off this incredible medical mystery. And believe it or not, the most important clues are hidden right there, in their blood. Okay, let's get into it. Doctors basically become detectives. Their first move? Draw blood. They're on the hunt for these tiny telltale signs, chemical footprints left behind by a heart that's in trouble. So the real question is, how do they read these signs to save a life?
All right, so the first step in cracking any case is knowing what evidence to look for. And we're not talking fingerprints here. We're talking about something called biomarkers. These are the crucial chemical clues that tell the real story of what's happening inside the heart.
Here's a simple way to think about it. When heart muscle cells get injured, they kind of break open, and their contents spill out into the bloodstream. Those substances that get released, those are the cardiac biomarkers. By measuring them, doctors get a clear picture of whether the heart's been damaged and maybe even how much. Now, every good detective story has that one lead investigator, the one who's just the best in the business. In the world of cardiac biomarkers, that lead detective is called troponin. So, troponin is a protein that's supposed to be inside your heart muscle cells. When those cells are damaged, say during a heart attack, troponin spills out into the blood. It's the most reliable clue we've got, the one that almost always cracks the case wide open. This quote really nails why troponin is our star player. Myocardial is just a fancy word for heart muscle, so it's the most sensitive and specific biomarker for heart muscle injury. Sensitive means it can pick up even the tiniest amount of damage, and specific means that when we find it, we're pretty darn sure it came from the heart. It's the smoking gun. And what makes troponin so incredibly useful is its timing. It doesn't just show up. It follows a really predictable pattern. It starts to climb about 3 to 6 hours after the injury, hits its highest point around 12 to 24 hours, and then it hangs around, slowly coming down over the next week or so. This timeline is absolutely critical because it helps doctors confirm not just if a heart attack happened, but gives them a good idea of when. And the tech just keeps getting better. These new high-sensitivity troponin tests can spot the clues way earlier and at much, much lower levels. What that means in the real world is that doctors in the ER can make a diagnosis and start life-saving treatment faster than ever. It's a total game changer.
But, even the best detective doesn't work alone. Troponin might be the star of the show, but it has a support team. Other specialists who get called in for very specific situations. Let's meet the rest of the crew.
So think of troponin as the first responder on the scene. It's perfect for diagnosing that initial event. But what happens if a second heart attack occurs just a day or two later? Well, the troponin levels might still be really high from the first one, which could mask the new one. And that's when you call in the reinforcements, cKMB. cKMB is another enzyme from the heart muscle, but its superpower is that its timeline is much shorter. It pops up and then gets back to normal within about 2 to 3 days. So if a doctor sees a fresh spike in cKMB while troponin is still high, that's a huge clue that a second event, what they call a reinfarction, has just happened.
So all the clues we've talked about so far point to heart muscle damage. But what if the heart isn't damaged, but it's just struggling, overwhelmed, and having a hard time pumping? Well, that's a condition called heart failure, and that's a whole different case that needs a different kind of specialist.
And that's where BNP comes in. This isn't a marker of damage, it's a marker of stress. When the heart's big pumping chambers get stretched out because they're working so hard, they release this hormone. So seeing high levels of BNP is a clear signal to doctors that the patient's shortness of breath is probably coming from heart failure. Okay, so we've got our team of detectives, troponin, cKMB, BNP. But just finding the clues, that's not enough. The real detective work, the real art, is in reading the patterns. A single blood test is just one snapshot in time. It doesn't tell you the whole story. You see, someone might have a slightly high troponin for a chronic reason, like kidney disease. The key to solving an acute case, like a heart attack happening right now, is watching how those clues change over time.
And this is pretty much the standard playbook in modern emergency rooms. They'll follow a protocol, like this 0 and 3 hour algorithm. They take a blood sample right when the patient gets there, then they grab another one 3 hours later. They're not just looking at the number itself. They're looking for a significant change, a rise or a fall, that they call a delta.
And this is exactly why that pattern is everything. A stable level that's a little high might point to some ongoing chronic issue.
But a level that's actively changing, that's rising and falling, that is the classic signature of an acute injury, like a heart attack that just went down. The pattern tells the real story.
So, after collecting all these chemical clues from the blood and looking at the patterns, how do doctors actually make the final call? Well, as powerful as these blood tests are, they're still just one piece of a bigger puzzle. A rock-solid diagnosis really comes down to what's called the diagnostic triad. First, you need the biomarker evidence, our blood test clues. But you also need the clinical findings. What is the patient actually feeling? What are their symptoms? And finally, you need the ECG, which is like a real-time electrical snapshot of the heart. Think of it like photos from the crime scene. And this, right here, might be the most important takeaway of all. A high troponin level, all by itself, does not automatically equal a heart attack. It tells you there's heart injury, sure, but that injury could be from something else, like a big clot in the lung, a severe infection. The blood test is a fantastic lead, but you have to back it up with the other evidence to officially close the case.
Of course, there are other players in this world. Some biomarkers, like LDH and AST, are pretty much historical relics now. They're largely obsolete. Others, like CRP, tell us about general inflammation and can help figure out future risk. And then there's D-dimer, which is used to investigate a completely different crime, blood clots. So they all have their own very specific and often limited role.
It's pretty amazing when you think about it. From just a single drop of blood, we can now piece together this incredibly detailed story about our most vital organ. And as the technology gets even more sensitive and precise, that story is only going to get richer. It really makes you wonder, what new secrets, what new warnings will our blood be able to tell us in the future?